So we'll go ahead and get started here. Welcome to our third webinar in our IS group, our IS Provincial Network here. So just to kind of run through again, because I'm sure we have some new participants, this network was developed to share information about provincial initiatives, strategies, and tools related to improvement facilitation and quality improvement in primary care. Everything you learn about and all the ideas you get in these calls are meant to be applied in your own context, and so sometimes some things might not apply to you, or they might. So for the call today, we'd like these calls to be as interactive as possible, so please use the chat feature. The chat feature is along the right side of your screen, and under the Send To section, if you could make sure that you're sending to all participants. That way we can all see your questions and comments. So let's start by testing out this chat feature and finding out a little bit about who's on the call. So if you wouldn't mind putting your name and which organization you're from into the chat feature, and we'll have a look at who's here. Looks like once again we have people from all over the province. The names are all rolling in. I'm sitting here in Edmonton. I didn't introduce myself at the beginning. My name is Sandra Stable, and I work for the Edmonton Southside PCN. And those of us in the Edmonton area come together for these meetings. So I'm in the same room as a bunch of folks from Edmonton North PCN, Edmonton Oliver PCN. It looks like we have some folks from down south, quite a few from the Alberta Medical Association, some from the U of A. We have people from all over the province. I'll give another couple seconds here for everyone to get a chance to get their names up. And another little chat feature icebreaker here. Since we're all a group of improvers and we're all so great at change management, post your name and maybe your New Year's resolution or something that you'd like to improve personally or professionally in 2018. I think I'd been muted for the last little bit, so I have no idea what you heard and what you didn't, but I was narrating a little bit what was in the chat. But we'll move along from that, I guess we all saw.
Yeah, it sounded like we went into silent mode there, and then everyone was posting their things.
Oh, okay. Sorry. Well, everyone in Edmonton heard my narration. Sandra again, sorry about that. I think Dr. Luello and Dr. Gelber, we probably missed everything from the beginning. So I'm sorry to make you do this, but if we can just start back at motivation with the first question, and we'll get going from there. Okay.
So where I had gone with that is I was saying that one piece that's commonly overlooked is the what's in it for me, for the docs who are maybe having some difficulty with motivation. You know, we've all seen the diffusion of innovation curve, and you know, we're I think through the innovators and even the early adopters. The conference is now
in silent mode.
And I think that, you know, once we're into the late adopters and whatnot, that we have to change the message a little bit in terms of what's in it for them, because they need some tangible reasons why they should be putting in the effort to make the changes that are required to take them out of their comfort zone, take them out of the routine that they're used to, engage their staff in new tasks for something that they don't necessarily see benefit in. And so that question, I think, really needs to be addressed early, upfront, and often.
Tobias, this is Mia Kavanaugh. I'm just sort of sitting back on the sidelines today monitoring the chat, but we did get one question from Magda, and she said, how do you correct the misconception that QI changes are more often more process, not necessarily always people?
I mean, that comes down to messaging. I know when we were doing a lot of AIM work, you know, it's the measurement is for improvement and not for judgment. So that had to be emphasized over and over again, that we're measuring you so that we can actually help things get better. We're not pointing fingers at you. And there's a similar sort of thing with this, is that nobody comes to work thinking, I'm going to do a bad job today. everybody comes to work thinking I want to do the best I can for the patients and the organization that I'm serving, but there's many times there's process things that get in the way of our ability to do things correctly. And so when we examine the way that things happen, when we examine flow and whatnot, we find that there are some process things that get in the way of our ability to do the best job that we can. And so even though those processes are often performed by people, but if we are able to change the way that things are done, then we can often expect some better results. But when we ask people to potentially look at the way they're doing things and do things differently, some people automatically assume that I'm doing it poorly, which is not the case at all. It's just the process and the way that it has been advised that they do things that needs improvement.
Thanks, Dr. Yelber. This is Mia again. So I'm just wondering, we'll have to move to the next slide here pretty soon here, but one of the questions on this slide was, how do you keep the motivation going when new projects or new things are coming? So we have, sometimes they're stacking one thing on top of another and sort of always being added to the workload. So what are some of the things that you think might be useful in talking to physicians about that?
Any thoughts, Christine? Christine, muted. You know, one of the things that I've seen done for sure is to make sure that the existing projects are not forgotten about and that there is potentially recognition and even celebration of some of the previous projects, recognizing the amount of effort and work that has been done. And then still coming up with good rationales and explanations of why we are embarking on another project. The work that we do is an ongoing evolution, and there are so many facets to the work that we do that we can find ways to improve all of them. That appetite for change is going to be variable from organization to organization, and you really have to balance the desire to improve everything against change fatigue and people's energy levels and that sort of thing. So there's definitely a balancing act to be had.
Do you find, Dr. Gilbert, that, and hopefully we'll get Dr. Lilo back, but is there a way to help physicians prioritize maybe? Because I think sometimes as an IF we say, okay, well this isn't work that necessarily, like panel validation, for example, it's not exactly something that the physicians always have to do. It's primarily a job done by the girls at the front desk or on the phone. So is there a way that we can help them prioritize maybe?
Yeah, I mean, certainly if you look at, in particular, the one slide about the patient's medical home that has some of the various components that are needed to get to the patient's medical home, there are foundational pieces that are very, very helpful to have in place so that the rest of your improvement work can get better. So that's things like having good paneling processes in place, and while that may not be the sexiest thing in terms of improvement, it's certainly essential for so many different components. So emphasizing that and building on the work that the PCNs have done and that the PCN PMO has done on paneling. We're now going to be moving into continuity work as the next step over and above panel, and I think you know, jumping in on that as well will be quite helpful, because I think most physicians can identify with the concept of continuity and wanting to see the same patients over time. That's why a lot of primary care docs chose to be in primary care, was because of the continuity aspect. And so when we start to focus on that, I think they'll be able to identify with that quite well.
Are you guys able to hear me now?
Yes.
Yes. Okay, great. There was something wrong with the line I was on. I've been trying to talk for the last 5 minutes, but I haven't been leaving you to your own, Tobias.
No worries. I kind of figured it was technical.
Yeah, so yeah, if I can chime in, one of the things that we did very early on in our PCN was we we made this very much a grassroots kind of initiative in our PCN, in that we had individual clinics kind of drive the process individually rather than parachuting in a panel manager from the PCN, because we intuitively felt that if there was a drive from someone within the clinic to do this work, we would get further, although it's made us get further with each individual clinic. It's a slower process. We tried to get docs who weren't necessarily as interested on board with the idea of measurement by drawing an analogy to the work that they do every day in the clinic. So, for example, saying to a doctor, well, why do you measure someone's blood pressure? Well, so I know whether to change their medications or not, or what information to give them when they leave the appointment. And we really said things like time to third next is like the blood pressure for your practice. And looking at those measurement tools in that context, I think, helps some docs say, okay, I can get that. And then, you know, really, as you said, Tobias, being careful with the messaging, because we can certainly say to our doctors, you need to measure time to third next because that's how we get our funding as a PCN, but really giving them almost like a menu of different outcomes they could expect from using that time to third next as far as positive outcomes, whether that's leaving clinic on time at the end of your day or having same-day access for your patients without doing a full AIM initiative in their practice. And for myself, having just arrived home from vacation yesterday, because of some of those process-driven outcomes from our time to third next work that we've done, I actually have appointments open for the rest of the week, and I didn't hit the ground today with a kind of like double the number of patients I might have needed to see had I not been watching things like my time to third next leading up to my vacation.
Yeah, and going back to the last question, I would agree that this concept of a menu is very useful, because then giving the docs and their clinics the choice of what they want to work on, I think gives them a feeling of a lot more empowerment and control. And, you know, they're going to pick what they feel is most relevant to their practice, and as opposed to telling them this is what you have to do. So if there's a variety of different projects that are, you know, all in sort of a similar weight in terms of, like, let's say there's half a dozen different clinical indicators that could be improved upon, then picking one or two of those as opposed to saying you have to work on diabetes or you have to work on hypertension, et cetera.
And I think with regards to physicians and motivation, as you said earlier, Tobias, like, physicians don't go to work thinking, I want to have crappy processes in my clinic today. We go to work thinking we want to help an individual patient in the next visit, and we all suffer from, you know, what's been called the tyranny of the urgent, and that's that thing that's right in front of me that's so urgent. And we forget to apply some of those ethical principles around the fact that if you're so busy on that kind of treadmill or gerbil wheel, if you will, doing the work that's right in front of you, you actually don't provide good care for the rest of your panel. And so trying to help docs see that the work they do every day can be spread out around their panel if they do some of these types of process changes. And I think the other thing with regards to motivation, you know, the second to last question here is the keep the motivation going. I think we need to be careful about our expectations around change management with physicians in their offices. Improvement facilitators and panel managers are kind of immersed in this work, and this is a piece of what docs are doing in their day-to-day clinical work. So, for example, in my office, we've been working on panel management and whatnot and ASAP maneuvers for about 2 years, and we're a clinic of 3 doctors, and I was very much the driver for our team to do this. And it was literally just 2 months ago that one of my partners came to me and said, hey, there's a new recommendation for screening men over the age of 65 for abdominal aortic aneurysms. Could we get Margot, who's our panel navigator, could we get Margot to run a report to show us how many guys we have of that age and start setting them up for ultrasounds? And I just about fell on the floor, because up until now, she's never stopped us from doing anything, but hasn't necessarily been all that keen on it either. And now all of a sudden she is. That's 2 years in. So you want to set your expectations as an improvement facilitator carefully and don't expect too much too quickly, because I think the slow and steady really has a bigger impact in the end.
Thanks, Dr. Lilo.
Thank you so much for that, Dr. Lilo. I think that's very insightful. This is Sandra again. I've been in this position for 4 years, and I have some clinics that there are doctors that are just getting on board now after 4 years of working together. So that's so true. And sometimes we're trying so hard to move things along that we don't respect the natural pace of change. So let's move along to the next theme. The next theme is more specific to patients. And I know in my conversations with physicians, patients come up all the time as almost like a barrier. Well, patients don't know that. Well, patients need to know that about their screening, and how do we empower the patients? And so I'd love to hear your insights on this.
Tobias, I'm going to jump in here. I was just part of a committee or some work that was done through Imagine Citizens Collaborating for Health. They had a grant from Alberta Health to do a project around patient experience and attitudes around the idea of attachment. And this was a key question that was being asked in this project was, how much do patients understand the benefit of being attached to a family practice, and how much do they understand the work that the family practice / physician can do on their behalf even when they're not actually attending the clinic? And so that's actually just being presented to Alberta Health in these past few weeks here, and we hope to see something go public here probably in the next month. And that's going to actually inform a patient education strategy around this. So I think that's going to be super helpful for the work we're talking about. But I think what we found in our clinic is that as we talk to patients around the fact that there's nurses who are going to be calling them to tell them about them being due for their mammogram, and we let them know that we're doing this behind the scenes, we've only had really positive feedback. But it does take a lot of time as a physician and as your team members, your MOAs and your LPNs, to get the message out there. There's no quick way to do this in a way that's going to be, again, really lasting and meaningful, that I can see anyways.
So I definitely agree with all that. In addition to that, patients tend to learn through experience. And many times the behaviors that they have learned currently about going to an emergency department or a walk-in clinic is based on their experience of not having been able to get into their primary care physician when they need to. Access is so important to patients and to the general public that they will choose access over continuity in many cases. And so it behooves us, if we are wanting to do the best we can as primary care providers, to try and ensure that we have access. And of course, that is a multifactorial, or there's many factors that are involved in access. Right size panel, of course, is one. The balance of supply and demand, hours that we're open, use of a team, and the list goes on. And so, if we want patients to know about the continuity and to respect that, then we have to reciprocate on the delivery end and be able to provide what they need and want. We can't expect them to say, okay, now that you've told me how good continuity is, I'm okay to wait 2 weeks to come and see you just so I can see you, because that's not going to happen. So we can send the message, but we also have to build a system to accommodate what the patients need.
Yeah, and I think further to that, because you can be working on your access and improving that to a place where, as you said, you can always have that same-day access. I'm always sensitive to that for my patient panel because of the administrative work I do. I'm not in the clinic all the time. And so what we've done for my panel is explain the benefit of that continuity and understanding when patients aren't physically able to see me because of my other work, is helping them to be partners in that informational continuity. So if you're going to be seen at a walk-in clinic, give us a call afterwards to let us know if something was ordered so we can look for it on NetCare. And I know a couple of practices in our PCN have made this very formal with a document that both the physician and the patient signs. It says, here's what I'm going to provide for you, and here's what I expect of you. And if we both hold up our end of the bargain, then we're going to have that continuity, even if it's always face-to-face continuity. But again, that can be a tricky conversation, if you're asking a patient to sign a document like that. It's super important, I think, that you as a physician give the same message to your patients that your staff gives to them as well. And so that's where those team meetings where you're all on the same page and you're making sure that if you've crafted a particular statement to give to patients about you not being available, that your staff understands why you've crafted it that way so that they can use it with authority.
Mia and Sandra, it looks like there is a question around how do you talk to those patients who think a full waiting room equals financial security, those physicians who think a full waiting room equals financial security and are maybe less concerned about access?
Well, there's the big question, right? And I think that one of the pieces of work that the AMA is doing in the section of general practice is around creating that financial incentive for continuity in a way that's much more meaningful than what it had, because in the past it's like the more people you saw, the more you made, and then the hope for the future would be that continuity would be rewarded financially and discontinuity would be disincented. Is that fair to say, Tobias?
That's exactly the principle that we're working on. You got it. That's taking it down to try and persuade the late adopters and reward those that are already doing it, that this is the direction that the section of general practice values and wants to reward. Trying to build the system that incents the type of behaviors that we're trying to promote.
We had one physician in our PCN who's nearing retirement, and he's amazing doc. His patients love him. His access is absolutely brutal. I think like 4 to 6 weeks to see him. Most of his patients end up seeing a walk-in clinic before they see him, but they love him and they'll never leave him. And when he was talking about this type of work initially, and he just didn't understand why he should make any changes at this point. And one of the things I said to him is, well, what's going to happen to your patients when you leave practice? Because, a new grad is not going to come in and take over your practice when you haven't got a clean panel and you haven't got processes in place with your nursing staff and all these types of things. And it was a real aha moment for him because he hadn't really, the way that he works really was about his patients, but he couldn't look at it from a different angle. And when we talked about how his patients would actually potentially be at risk when he goes to retire, that was his aha moment around why he needed to make some of these process changes, which was quite interesting because, when you only have about 5 years left of practice, you'd think, why would you make a big effort to make changes?
Thank you so much. So the next topic is more specific to teamwork. And I can't change the slide. Oh, there it is. All right. So you've already alluded to quite a few times to the importance of teamwork and team meetings and having everyone on the same page. I'll let you speak a little bit more to teamwork.
So I think here in South Calgary PCN, a little bit different than probably what you've gone through, Tobias. So I'll speak to kind of the urban perspective. So again, in our PCN, we have improvement facilitators who work with the panel managers within the clinics, but the work is really being driven by the clinic with facilitation and expertise coming from the PCN rather than a PCN hired navigator being put into the clinic to do the work. And so the first question here about, how did your clinic make one big team with your PCN? I would say that we made one big team within our clinic and that we benefit from the support from the PCN, in our case, both financially as well as from an improvement facilitator perspective. So the PCN will come and present to us every 6 months on what our data looks like. It's been gathered on a weekly basis by our panel manager and then been vetted by me as the physician lead. And so we focus more as a one big team within our clinic because we recognize very early on that if every single person that has a touch point with a patient or a patient chart isn't understanding the process change around improving screening and those different things, if everyone's not doing it, then things get missed. It can't be left just to one person. And each staff member within our clinic has had an opportunity to have one of those really great moments with a patient where maybe a patient has said thank you to them directly, or where they've caught something that maybe would have fallen and they've felt that real sense of personal pride that they had that impact.
Dr. Lebo, this is Mia Kavanaugh on the line again. I just want to actually make a follow-up question to that. So, and I'm hoping it's something that everybody would like to know. So the second question on this particular slide was, what are some of the most strong effective points or ideas that you use to get buy-in from your team? And I'm just wondering, from your perspective, if you had an improvement facilitator or somebody from the PCN come into the clinic, what did you observe as being like very effective with your team? Like, what are the kinds of things that an IF or a panel manager or somebody from the PCN can do to get your team to buy in?
So I am absolutely blessed with a team member in my clinic. Her name's Margot, and she's actually an RN by training, but has her certification lapsed years ago when she had her kids. So she's always worked for us kind of in a LPN MOA type capacity, but with some RN training. And she, like myself, has just enough obsessive compulsive disorder to make her highly functional. So she's a real detail person, and everyone in the clinic has always known that about her. So she was our obvious pick for being our panel manager, and I think where she was able to get the rest of the team on board with the additional workflow was around just doing small little bits at a time. So not trying to throw 20 different things with them all in one day, week, or month, but just saying, well, let's do this small thing this way, and then circling back to them, on a daily basis and saying, how's that working, and being really open to feedback, saying, well, that doesn't feel right, that's not working well, and then coming up with, okay, well, how could we do it differently then to get the same outcome? So we've tweaked and changed and, on a daily basis, I'd say, for most of the work that we've done. Does that answer the question?
Yeah, I think so. I think if anything, as there's a number of IFs on this call, I think we just need to know what are the things that we can do that you have observed to be the most highly effective in terms of our interaction with the clinics.
I think just being really open to, as it said at the beginning of the slide deck here, saying how does this fit with the work that you do within your clinic already? So if your clinic has a certain preferred way of working, how do we get the same outcome through maybe a different methodology in your clinic? So, if you've worked with a clinic and you're taking that idea to another clinic, is being open to the point that it might not work well for them, but it's just really a jumping off point. And being really creative around how something might work differently in a different clinic.
Is she there?
That's great. Thank you, Dr. Lebo. Dr. Gelber, did you have anything to add? Or?
Yeah, the one thing I was going to suggest was that we have to make sure that people know the difference between having a team in name only or a team in function. And so just because we've got people in various placeholders does not necessarily mean that we're a team. And so some of the best teamwork comes when we empower or this is essential, is that we have to empower all members of the team to be able to contribute. And one of the big stumbling blocks that I've seen is when there's a couple of very strong personalities who are accustomed to being in leadership positions, and you know, they sort of take control and direct everything without really listening to what other people's input. Many times that is the physician, but sometimes there are other strong personalities within leadership positions in the clinic that you know, don't fully engage or engage at all team members.
And I think, you know, if you say to the front end staff, we are trying to achieve this endpoint. Here's some ways that other clinics have made that work. Do one of those ideas, does one of those fit well with you? Or let's brainstorm together on how you might do it differently in your clinic, and we'll do a short PDSA cycle on it. And if that doesn't work after a few weeks, then we'll revisit it and try again. Because this work that we're talking about, again, to use a medical analogy, this is chronic disease management. You don't just treat a sinusitis with one course of antibiotics and you're done. This is a long-standing, reiterative process of growth and development and change, and I think you have to just always be open to making small changes every day if things aren't working properly.
Okay, this is Sandra again. Dr. Lilo, I have a question for you. I guess it's a little bit of a mix of motivation and teamwork. When we think of teams, we often think of just the team within the clinic or even just the team within the PCN. Is your PCN doing anything with regards to kind of teams between clinics and having maybe kind of peer physician program or physician champions that help other physicians along the journey?
Good question, Sandra. So when we started on our first pilot phase for PCN Evolution, it was my clinic, Dr. Ernst Gravenstein's clinic, and his clinic uses MedAccess, and he happens to be the chair of our governance board. And it was Dr. Paul Tung's clinic, and he uses Practice Solutions, and he was our physician champion for Access. So all three physician leads had fairly high-level leadership positions within the PCN, so we were well engaged in kind of what was happening provincially, and had already been really engaged in PCNs in general, so you could say, you know, we drank the Kool-Aid. And then what we used to do actually early on in the first year is the three of us physicians would meet on a monthly basis to talk about any challenges we were having and brainstorm around, especially things like getting the team feeling more like a team and how to tackle certain things, even around, you know, from a malpractice perspective, you know, some of those interesting conversations we had. You know, what do you do if a physician leaves the clinic and your panel manager has got all these reminders to call patients back in, those kinds of questions. And then as we brought on more clinics, each one of the three of us was put out there as a mentor for whichever clinic used the same EMR as us, because that becomes an interesting kind of cog in the wheel that if you're using Wolf, as I am, there's particular ways you've had to apply the process in your clinic based on what Wolf can and cannot do. So it's a lot easier to be a mentor to a physician who's using the same EMR, I think.
Great point. There's a couple of questions that just came up in the chat here. Carrie asked, how do your panel manager and improvement facilitators work together to help you with your clinic goals? I don't know if that's maybe more relevant to you, Tobias.
So, I mean, the panel manager clearly is someone in a role who has got a fairly defined role and relatively narrow scope, but will be, and so has to change or improve on some processes to do with paneling and then potentially outreach to patients. I think the improvement facilitator can help identify what those processes are and potentially give some suggestions on how you might improve upon those, alternate ways of thinking about them, or even talking with other members in the clinic about ways of either offloading work or engaging others to help out with the work, that sort of thing. I see the role of the facilitator as someone trying to enable some of the changes for people in specific roles.
Excellent, thank you. I'll just remind everyone, if you don't mind just double checking that you're on mute. There's quite a bit of giggling in the background, so I think that somebody may have forgotten to put themselves on mute, so that would be great if you can all just double check. We'll move along to the next topic on physician engagement, which I guess I kind of jumped the gun with from my last question, and I'll encourage everyone to keep using the chat feature on the side. We have a few questions rolling in, but please feel free to use it. Make sure you chat to all participants, but we'll start with having Dr. Lilo and Dr. Gelber talk to ways in which you've had success engaging your colleagues in your clinic as well as maybe colleagues across your PCN or even provincially.
Boy, that's a big topic. It really does speak to the diffusion curve a little bit, and the techniques change quite a bit, as well as the population that you're dealing with. I have been involved on the micro, meso, and macro layers of change, micro being my own clinic, meso being my PCN, and macro being the province. And certainly we use different strategies in different places. At the local practice level, we use a lot of data. We show people where they're at in terms of clinical indicators and in terms of some of the functional side of things, and like third next available for wait times and no-show rates and those sort of things, because physicians typically respond fairly well to data and to numbers. When we get into the PCN level of things, my experience has been that we very much see the diffusion curve. We, try and provide support to the early adopters and the innovators, and then we've had to have some different approaches for the late adopters that are definitely a different strategy. So one of the examples of this is that we've been looking at clinical indicators. We've been providing people with data. We have about a dozen different clinical indicators that are fed back to clinics on an anonymous basis. All the clinics get to see everybody's data, but the data is anonymized, so we don't know who they are. And what we found is that we really were not affecting the change or the rate of change in several clinics, and these happen to be at the bottom. And so it was decided that we would, and so the initial steps were the PCN would reach out and offer any kind of support that could be needed or requested, and that still didn't make a change. And so we've now gone to the next step of unblinding data for two reasons. One is to put a little bit of pressure on folks so that other people are now aware of who they are, but also that allows them to be able to see who is functioning well and be able to potentially reach out to those higher functioning clinics to say, hey, you're from a rural, I'm from a rural, I'm not doing so hot, how can I help improve things? And so that the combination of those two things has really spurred some discussion and allowed people to become a bit more engaged and not want to be at the bottom of the barrel for the clinical indicators. And then another thing that we've started doing, for better or for worse, is where we have a central registry that we use in our PCN for paneling, and what we found is that not everybody is keeping up to snuff with their paneling processes, and so they are allowing more and more multiply attached patients onto their charts or onto their panels, and so we've put in rules that actually affect their PCN funding locally if they have too many multiply paneled patients. You know, that's kind of how we've changed over time, going from just providing support to actually putting in some I guess, penalties if you're not choosing to be continuing to work on things. So, and we are seeing significant results there. So, for the paneling process, for example, all we had to do was put in this threat of a funding cut, and we went from I think we were up around 18 or 20% of the patients were on multiple panels, and we dropped well below down into 8% or so. And so people just needed a little bit of structure and reminder about the importance of paneling. So those are a few examples of how we've engaged people with a few different strategies.
Thanks for sharing that. I think a lot of us struggle a little bit with that. You know, we've gotten to the point where we've engaged those early adopters, but we're unsure of what to do with those late adopters. And I think sometimes it takes a little bit of regulation. At our next call in February, the topic will be on resources and iHeart resources. And I'm wondering if your PCN would be willing to share those indicators, those 12 indicators you alluded to.
Oh, I'm sure. Yeah, you could just talk to our medical director, Peter McKernan.
Okay, perfect. Thank you. And so, Dr. Lilo, I'll give you the last word here so you can kind of get your 2 cents in, and then we'll wrap up in the next 5 minutes.
Well, I thought the first question on the slide was an important one. How much time do you spend in meetings at the clinic doing QI or medical homework? So our clinic, again, 3 doctors, 2 LPNs, 2 MOAs, and 1 referral/receptionist. And we have monthly meetings, actually, for about an hour, where we would do kind of the regular business of the clinic, but we always have a portion of that meeting that's specific to our panel management activities. And again, a lot of that conversation around what have you been doing for the last month? Is that working? Do we need to tweak it? Does anyone have any other ideas? And as a physician lead for the clinic, I speak with Margot on an ad hoc basis throughout the day, throughout the week. So whether it's, you know, trying to understand how we're going to run a rule in our EMR in order to flag patients for a complex care plan or for goals of care designation. So really, it's embedded in everything we do. So I think on a formal basis, about an hour a month, but on an informal basis, probably a few hours a month on top of that. And just wanted to speak to the second question here as well is, you know, the high interest physicians are really fun to work with, right? Because they get it right away and they're just super excited. I heard someone say recently that sometimes, or if you're a leader and you're too far in front of the group, you can also almost look like the enemy. So you want to make sure that the lower interest physicians do get an opportunity to come along at their own pace. And sometimes it's okay just to have physicians that are in the clinic and they're not really doing much to support the work and they're not really doing much to add to the conversation. But as long as they're not stopping the progress and as long as they're not you know, wrecking the work that's being done, I think that's where you have the real risk as a doc who's like actually in opposition to the work. So I know we've got physicians in some of our clinics that are like, yeah, I really don't care. I don't mind that it's happening, but I'm not really going to put much effort into it. And I think as Tobias work comes along with the section of general practice and the AMA and the billing and all of that, those docs will come on board because they need to see something more tangible in the form of dollars in order to come along. So I would say for the improvement facilitators, if you notice that there's a physician that has low interest, maybe don't be too worried about them, but if you've got a physician who's showing resistance, those are the docs you really want to try and have a conversation with. And to the final question here is asking them questions around what it is that maybe what is it they're afraid of is going to happen. And that may not be a question that an improvement facilitator can have with the physician, but maybe one of the other physicians at the clinic can have that conversation with their colleague. Because if the, you know, physicians, we were bred to be competitive, you know, right from the get-go, getting into medical school and getting into a residency. So I think that's where Tobias has noticed that change when it was a bit more competitive and the names were unblinded, that docs were like, oh God, now people know I'm at the bottom of the heap. So you can sometimes use that to your advantage.
Excellent. Thank you so much. Thanks both Dr. Gelber and Dr. Lilo for your time this afternoon. We really appreciate your insights. So helpful to hear it from the source. And you've addressed the questions really well because we kind of just threw big slides at you. So thanks so much for your time. I also want to apologize to everyone on the line about the technical difficulties we're having at the beginning and then still struggling a little bit with some chatting in the back. We'll review how we manage these calls in the future to try to minimize that, because I know that can be really frustrating when you're trying to pay attention. So a few things to note here before we end the call. In the new year, it is the new year. On January 31st, the 2 AMA offices will be hosting an afternoon of replayed sessions. So the IHI, the Institute for Healthcare Improvement, held a forum in Orlando, Florida last month, and so the AMA is going to be putting on kind of the top 3 talks over the afternoon on January 31st from 11:30 to 4:30. They'll serve lunch, and there's 25 spots per site available. So we'll send an email, or an email reminder will be sent after this, and so you can choose to RSVP if that works with your schedule. And lastly, next month, the topic will be I Heart Resources. And so we encourage you all to please share your favorite resources with us so that we can share them on the call. So really anything you're using, anything from a database to a handout. I'm sure some of you have maybe, you know, invested in some design work for things that you share with clinics. So the whole point of this network is for us to learn from each other and not continue to reinvent the wheel. And so it'd be awesome to see what people are doing across the province. So if you have any resources, go have a look in your kind of on your documents on your computer and email them to ifadmin@albertadoctors.org. And then all those resources that are shared will also be posted on the Collaborate site. And I believe that is it for this afternoon. Thank you so much for your time, and we'll see you all on February 5th at 2 p.m.
Okay, thanks very much.
Bye.
Thank you.
Bye.
Bye.